I'm going to start by talking a little bit about Sjögren's disease, just to introduce it, and the classification criteria. This is the agenda I will follow. Well, as we know, Sjögren's disease is a chronic autoimmune exocrineopathy of unknown cause and slow progression. It is also known as autoimmune epitheliitis because it affects the epithelial cells of the exocrine glands. These cells are the target of the inflammatory response, resulting in a lymphoplasmacytic infiltrate. As a result, it causes dryness of the oral mucosa, known as xerostomia, or of the eyes, known as xerophthalmia. And as a true systemic disease, it can also produce extraglandular manifestations, which I will discuss later on. We classify Sjögren's syndrome as primary when it is not associated with any other condition, appearing on its own, and as secondary when it is associated with another autoimmune disease, such as lupus or rheumatoid arthritis. Just a brief note on the epidemiology. It has a prevalence rate of around 0.54% in the adult population, with a higher prevalence in females, with an onset age typically between 40 and 60 years. And it is more prevalent in the Asian population. A certain genetic predisposition has been observed, as well as some association with viral infections such as Epstein-Barr or cytomegalovirus. There is also a risk of developing B-cell lymphomas, especially the MALT type. Just to mention, there are some factors that can predispose us to this disease, such as hormonal factors, especially in women of childbearing age. Certain immunological factors, which are the ones that will later give us the serological characteristics, features of Sjögren's syndrome, such as hypergammaglobulinemia, and certain genetic factors that can predispose us to this disease. Just to mention the HLA-DR3 antigen, and just a brief overview of the clinical manifestations we may find in these patients, which we will divide into glandular and extraglandular manifestations. At the glandular level, as I've already mentioned, we will find oral dryness, known as xerostomia, with a decrease in salivary flow and hypertrophy of the salivary glands, as well as a greater predisposition to oral infections and the development of cavities. It's important to remember that this xerostomia is not a disease in itself, but rather a subjective sensation experienced by these patients. There is also dryness at the ocular level, or xerophthalmia, also known as keratoconjunctivitis sicca, with reduced tear production, photophobia, and the development of certain complications, such as corneal ulcers, uveitis, and episcleritis. There is also nasal dryness, formation of nasal crusts, recurrent nosebleeds, pharyngeal dryness, difficulty swallowing, and difficulty speaking. Vaginal dryness, dyspareunia, and a greater predisposition to developing vulvovaginal infections. Also at the skin level, these patients will experience increased skin dryness and will have less elastic, more flaky skin. Additionally, as I mentioned earlier, being a true systemic disease, it will affect multiple organs and systems beyond just the glandular level. At the musculoskeletal level, it can cause arthralgias associated with arthritis. Other manifestations may include Raynaud's phenomenon, vasculitis, pulmonary involvement such as pulmonary fibrosis, and gastrointestinal and hepatic involvement. It can also affect the kidneys, as I will explain later in the topic, impacting the tubules and potentially leading to tubular acidosis as a consequence. It can cause peripheral neuropathy, autoimmune thyroiditis, and patients may also present with constitutional symptoms such as fatigue and fever. Now, just to bring to your attention the classification criteria, I will name the two most widely known and extensively used. The 2002 criteria from the European American Consensus and the later modification made to these criteria in 2016 by EULAR ACR. Simply put, for your understanding, the 2002 criteria are divided into 6 groups. Main components. We have symptoms related to the eyes, such as ocular symptoms, and oral signs, impaired salivary function, the presence of antibodies, and salivary gland biopsy, for example. It's important to emphasize that the first two are objective while the rest are subjective. Also important to note is that for antibodies, only anti-Rho and anti-La are considered, and neither the rheumatoid factor nor ANA is taken into account. And this is important because by requiring the presence of anti-Rho or anti-La antibodies or lymphocytic infiltration in the salivary gland biopsy, this increases the specificity of these criteria, reaching approximately 94.2%. Also, in order to make the diagnosis, 4 out of the 6 criteria must be met, which is also useful for establishing the diagnosis, such as in clinical practice. If 3 out of the 4 that I mentioned, which are objective, are met, and it's also important to note that systemic manifestations are not included here. Regarding the modification of these criteria in 2016 by the ACR-EULAR, it presents a patient profile in which at least one symptom of dry eyes or dry mouth must be present. And here, unlike the previous one, systemic manifestations are indeed taken into account, requiring at least one positive domain in the STI evaluation. This also takes into account lymphocytic infiltration in the salivary gland biopsy, considers antibodies, but here it only considers the positivity of anti-Rho antibodies and not anti-La antibodies, as well as ocular signs, altered salivary flow, and here it is worth emphasizing, which include a series of sialogogic drugs that can cause dryness of the mucosa and also include certain exclusion criteria such as hepatitis C, sarcoidosis, amyloidosis, and in order to be able to make a diagnosis of Sjögren syndrome in primary care, they must meet at least the score greater than or equal to 4, and that there are no exclusion criteria present. Regarding the differential diagnosis, since this disease mainly affects the salivary glands and oral glands, and the eyes, we need to perform a differential diagnosis with all other diseases that can also affect these areas. Particularly noteworthy is aging, which is the most common cause. Also, a variety of conditions such as sarcoidosis or infections like AIDS or from hepatitis C, which we know can closely mimic Sjögren syndrome. We also need to take into account the medications our patients are taking that can cause dryness, such as antihistamines, antidepressants, antipsychotics, and anxiolytics. And also those diseases, including but not limited to various conditions such as neoplasia or sarcoidosis, cirrhosis, etc., which are known to potentially cause a noticeable and sometimes significant enlargement of the salivary glands. And now simply to give us an idea of when we should suspect that we are dealing with Sjögren syndrome or disease. When we have a patient presenting with a dryness syndrome, ocular, oral, vaginal, when they have developed complications resulting from this dryness syndrome, such as aggressive cavities or candidiasis, or a patient who is being evaluated for an enlargement of the salivary gland. Salivary gland, a parotidomegaly, when we find an antibody panel, ANA, anti-Rho or anti-La, with a very high ESR but a normal CRP, and when we observe systemic manifestations, as I mentioned earlier, that are characteristic.